alaikum. I'd like to share with you this very interesting case that I have seen during my practice. My patient is a 26 years old, previously healthy Saudi male patient that he presented to King Faisal Hospital on 15th of February 2010 with 8-week history of headache, repeated partial convulsion involving his left side, and left lower limb weakness. He denied any history of loss of consciousness or visual disturbance. He also has history of cough with whitish sputum with frank hemoptysis on and off. He denied any history of chest pain, shortness of breath, and fever. No anorexia or weight loss was reported by the patient, and no history suggestive of autoimmune disease. He has no history of smoking. He's not alcoholic and not IV drug abuser. He's working as an officer, and he's father of 2-year-old healthy girl. He has no history of recent travel or extramarital relationship. On examination, he was fully conscious and oriented with average body build. He was afebrile, and blood pressure was 102/72 with heart rate of 123 beats per minute. Oxygen saturation was 97% on room air. He has no oral thrush or lymphadenopathy. His chest examination shows decreased breath sound on the right base, and abdomen showed no organomegaly or ascites. His CNS examination showed intact higher function, no cranial nerve lesion. He has hypertonia in the left lower limb and power of 4/5 in the left lower limb with hyperreflexia and sustained ankle clonus. Okay? His investigation, basic investigation showed white blood cells of 8.4 with normal differential. His hemoglobin was 130, platelet 356. His renal and hepatic profile both were normal, and his septic screen was negative as well. This is his chest X-ray on presentation. Any comment on the chest X-ray? Anybody can comment? Okay, we can see infiltrate. He has, yes, this opacity in the right cardiac border and the right lower lobe. This was his CT brain on presentation, which obviously showed.
Check his radiologist from your reading, right? No. But you're doing well. Can you help us also? So we see the ring-enhancing lesion in the screen?
Yes, it's a ring-enhancing lesion in his CT brain on presentation. This is his CT chest on presentation, which showed mediastinal soft tissue mass, okay, and some opacity here, okay? So, what is the differential diagnosis of this presentation? Young patient, previously healthy, presented with CNS symptoms and respiratory symptoms with brain lesion and lung lesion. What can be the differential diagnosis? What are the possibilities here?
Chest and brain lesions.
Yes. Okay. One is multifocal TB. What else can be? Lymphoma, malignancy. So, anything else? What?
Other infection, political loss.
Yes. Okay. Anything else? What? Infiltrative diseases like? Yes. Yes. Yeah. Okay, so it could be multifocal TB, okay? It could be bacterial lung and brain abscess. It could be hydatid cyst. It could be metastatic tumor or nocardia infection. Any other possibilities? Okay, other differentials can be infective endocarditis with septic emboli, cryptococcal infection, invasive fungal disease and vasculitis. Now, what is the most definitive diagnostic test you would request now in this patient? Bronchoscopy with bronchoalveolar lavage, or tissue biopsy, or echocardiogram, BBD, or EGRAS? What you will request, definitive diagnosis? Bronchoscopy? Yeah, most likely I will go with a tissue biopsy, okay? And that's what we did. Brain biopsy was done on 17th of February, and this was the finding. Anything you can see here? What is this? What is it? Yes, this is fungal hyphae. Type. What we can see is septated fungal hyphae here. Okay, and the report came as necrotizing granulomatous inflammation with fungal hyphae. All right? Okay, this was the culture. What you can see here? Yes, this is fungal infection again, and the report came as Aspergillosis species. Any further investigation you would request in this patient? He's a young patient with invasive fungal disease. Anything you would request? What? Yeah, HIV testing, it was negative. HIV ELISA was negative, and we confirmed it with negative PCR. Immunoglobulin level and subclasses were normal. HLV 1 and 2 were negative. CD4 was 390, and his neutrophil functions was normal. Another biopsy was taken from his mediastinal mass, and it showed fungal element consistent with Aspergillus, with similar morphology to the one seen in the brain, and no malignancy were detected. Okay? So, I'll talk briefly about invasive aspergillosis. First, we divide the fungal pathogens into two categories, molds and yeast. From the yeast, we have the very famous are Candida and Cryptococcus, and the mold, we divided them into aseptated hyphae and septated hyphae. Aseptated hyphae, usually it is zygomycetes, and the septated hyphae, we have the Dimeticious mold or hyaline mold. The Aspergillus is one of the hyaline mold, which is hyaline septated molds. Now, invasive pulmonary aspergillosis were first described in 1953, but since then, the incidence is increasing because of the use of immune suppression and chemotherapy. In patient post-hematopoietic stem cell transplant, it has two peaks. The first one in the first month, post-transplant, and the second when they develop graft versus host disease with its treatment. And usually it occurs with between 78 to 112 days post-transplant. What are the risk factors of invasive aspergillosis? Number one is prolonged neutropenia. Anybody with neutrophil count less than 500 for more than 10 days, or neutrophil dysfunction. Other patients at risk are those who are on prolonged high-dose steroid therapy, patient with hematological malignancy, those on cytotoxic therapy, and patient with chronic granulomatous disease, as well as advanced HIV. Okay, as we said, in hematopoietic stem cell transplant, the risk factors are persistent neutropenia, severe graft versus host disease and its medication, and patient with CMV infection. Okay, what about invasive fungal disease and immunocompetent patient? The risk factors for such presentation is COPD because of the structural lung disease, patient on systemic steroid, those with malignancy other than hematological malignancy, diabetic patient, patient with liver disease, and victim of extensive burn. This was a report of 5 cases of COPD who presented with invasive pulmonary aspergillosis. It was reported in chronic respiratory disease in February 2008. They reported 5 cases of patients with COPD. They were admitted to the hospital with either acute exacerbation of COPD or pneumonia. And 4 out of 5, they were diagnosed to have definitive invasive pulmonary aspergillosis, and 1 was probable pulmonary aspergillosis. And 4 out of them, they received antifungal medication, but unfortunately, 4 out of 5 died because of the respiratory failure and multi-organ failure. Another patient at risk to have invasive fungal disease while they are immune competent are the critically ill patient. We have one retrospective study, And they showed that 70% of invasive aspergillosis were found in patients admitted to the medical ICU without any malignancy. And another study involving 172 critically ill patients with positive sputum of aspergillosis. Of those 172 patients, 83 had invasive disease. And of those 83, 60% of them, they have no classical risk factor for invasive pulmonary aspergillosis. Another patient at risk are those who were infected with H1N1. This was a report of 2 cases following pandemic H1N1, and they thought that the invasive pulmonary aspergillosis were secondary to cell-mediated defect or disruption of normal cellular clearance, leukopenia, or high-dose steroid that was used for the treatment of the ARDS. So, few words about the diagnosis of invasive pulmonary disease. Usually, it's a challenging diagnosis. The gold standard is histopathological examination of the lung tissue. What we can see, as we saw in our patient, we can see septated acute branching hyphae invading the lung tissue. And this is 2 pictures which can show this. But the histopathological findings differ in patient post-transplant and in patient with neutropenia. In those post-transplant and graft versus host disease, they tend to have intense inflammation with neutrophilic infiltrate with minimal necrosis and low fungal burden. But in neutropenic patients, they have less inflammation with extensive necrosis and high angioinvasion and high fungal burden. Okay, what is the characteristic radiologic signs of early invasive pulmonary aspergillosis? Is it non-specific opacity or cavitary lesion or multiple nodules with halo sign or air crescent sign? No, early. The early suggestive. If you find it, you have to suspect invasive pulmonary aspergillosis. Yes, multiple nodules with halo sign, okay? How are you? This is the first thing, okay? When we start to have, the first thing that appear is the nodules, okay? And then it will be surrounded by this halo sign. What is it? It's due to the hemorrhage, okay? Because the disease is it causes angioinvasion. So this halo sign is secondary to the hemorrhage. We can see here two pictures showing the halo sign. And what is this? This is the air crescent sign. When the patient recovers their neutrophils, the nodules start to cavitate, and it will give this appearance of air crescent sign, okay? Okay, what are the serologic markers that can help in the diagnosis of invasive pulmonary aspergillosis? Is it serum galactomannan test only, or we can do serum galactomannan and bronchoalveolar lavage level, Aspergillus PCR from the BAL, Aspergillus antibody, or we can combine serum galactomannan and bronchoalveolar galactomannan with the Aspergillus PCR. B and C. Okay. هقولها بس ما حطيتها. Yes. Yeah. Okay. So I'll talk about each one of them. What is the galactomannan say? Galactomannan is a polysaccharide cell wall component that released during the Aspergillus growth. Okay, it was FDA approved in the serum with a threshold of 0.5 nanogram per ml. It can be detected several days before the symptoms or radiological findings, and it's most useful in patients with hematological malignancy and post-hematopoietic stem cell transplant than in post-solid organ transplant. It can be detected not only in the serum, but also in other body fluid like the bronchoalveolar lavage, the urine, CSF, and the pleural fluid. What is the problem with the bronchoalveolar lavage galactomannan test? It can yield false positive result. Okay, in 2 categories of patients. In patients who are colonized with Aspergillus, especially in those who are post-lung transplant, and if the fluid used for the bronchoalveolar lavage was contaminated with Aspergillus. Okay, this was a study published in the PMC Infectious Disease in 2010. It shows that galactomannan testing of bronchoalveolar lavage fluid is useful for the diagnosis of invasive pulmonary aspergillosis in hematology patients. It was a prospective case control study conducted between 1st of September 2007 till June 2009. And they came with the conclusion that bronchoalveolar lavage galactomannan is safe and useful in the diagnosis of invasive pulmonary aspergillosis. But they used here the higher cutoff, okay, with 1.1 to avoid the overdiagnosis of invasive pulmonary aspergillosis. Another study was published in the Clinical Infectious Disease comparing the Aspergillus real-time PCR assay with the galactomannan testing of bronchoalveolar lavage fluid. It was a retrospective study conducted over the period of 10 years, including 150 bronchoalveolar lavage samples from 137 patients. Of those 137, 16 were diagnosed to have invasive pulmonary disease, and 26 were colonized, and 97 was just negative control. PCR was done on all the samples of those patients, but the galactomannan was not done on 2 patients because of insufficient sample. They found that the sensitivity and the specificity of the PCR in this study was, the sensitivity was 100% and the specificity was 88%. For the galactomannan test, when they used higher cutoff, the sensitivity dropped to 67, but the specificity raised to 97%. And they came with the conclusion that both bronchoalveolar lavage PCR and galactomannan testing has advantage over the culture, leading to more timely initiation of antifungal therapy. And the PCR was highly specific for detecting Aspergillus with very few false positive results, and it has the advantage of distinguishing between clinically important species. Okay, the last thing is beta-D glucan assay, which was again FDA approved. And again, it's one of the fungal wall constituents, and has a sensitivity ranging between 50 to 100% and the specificity of 44 to 98%. Now, after we diagnose the patient, what treatment you will start this patient? Voriconazole, amphotericin B deoxychelate, or lipid formulation ampho or caspo? Voriconazole, okay? All right. This is the IDSA guidelines for the treatment of aspergillosis. For invasive pulmonary aspergillosis, the primary therapy or first-line therapy is the voriconazole. Why? Because they have a study that showed that with voriconazole, the patient tend to have a better outcome with less mortality than the liposomal ampho. But if the patient cannot tolerate voriconazole, we can use liposomal amphotericin, caspofungin, micafungin, or bosiconazole. Okay, so voriconazole was started on our patient on 24th of February with significant improvement. He was discharged home. He came for follow-up with occasional mild headache and blurred vision, okay? But he has no more convulsion or weakness. He was walking normally. He went back to his work. So what to do with this patient? Okay, with just mild headache and blurred vision. Would you change voriconazole to lipid formulation, or you will discontinue Vori and observe the patient, or you reassure the patient and continue the therapy, or order voriconazole trough level? What you will do? Voriconazole trough level? Yes, we will just reassure the patient and continue current therapy. It's well known that voriconazole can cause mild headache and transient blurred vision, especially after the dose immediately, okay? So it's not one of the big concerns that we have when we are describing this medication. So what are the indications of TDM, therapeutic drug monitoring? In case if we suspect treatment failure, if we are giving the patient treatment and he's not responding in the form of clinical or radiological improvement, or if we have toxicity suspected, like what? Visual hallucination, this is one of the indications, or hepatotoxicity, or encephalopathy, okay? Or if we have concern about drug interactions. What is the desired level? Ranging between 2 to 5.5 microgram. So what to do if we have abnormal level? If the level is below therapeutic level, we can increase the dose to 300 PID, or if it is above therapeutic level and toxicity is not suspected, we can just continue the same treatment and repeat the level in 5 to 7 days. If it is still high, then we can decrease the dose. But if the toxicity is not suspected, if the toxicity is suspected, stop the medication and reassess your patient, whether he needs further therapy or not, no more. So 6 months later, this was the CT brain of our patient with significant improvement, okay, as we can see here, and this is his CT chest. Significant improvement of the soft tissue, almost resolution. When to stop the treatment? Actually, there is no clear guidelines. For patient, they say that the minimal duration of therapy is from 6 weeks to 12 weeks. But again, you have to assess your patient in the form of clinical and radiological improvement. And regarding the immune status of the patient, if our patient will continue to receive, for example, let's say that our patient is not immunocompetent, he's just immunocompromised patient, he will continue to receive chemotherapy or immune suppressive treatment, we have to keep him on medication, okay? But otherwise, he will have another relapse, all right? Okay, thank you.